Hello everyone, I am myself Dr. 𝗑𝐲𝐫𝐢𝐚𝐴. I am the general medicine educator. So in this session, I'll be discussing a very important topic in the connective tissue disorders, that is systemic sclerosis. So what exactly is systemic sclerosis and what exactly is the definition of it? See, this is a disorder which is characterized by abnormal accumulation of the fibrous tissue within the skin and as well as the multiple organs. See, the another name for this systemic sclerosis is scleroderma, right? So the word sclero is like accumulation of the fibrous tissue and derma is within the skin, and it is not only within the skin, but first it was observed that the fibrous tissue is getting accumulated within the skin. So initial name was scleroderma. Later it was found that the fibrous tissue is also being accumulated in the multiple organs. That is the reason why the recent terminology is systemic sclerosis. And in these patients, because of the accumulation of the fibrous tissue within the skin, right, the skin becomes very hard, right? The skin becomes very hard. And what are these multiple organs which are affected in patients with the scleroderma is the involvement of the GAT, involvement of the kidney, involvement of the heart. There is also involvement of the lungs, right? So these are the multiple organs which are affected in patients with the multiple systemic scleroderma or systemic sclerosis. And this is an autoimmune disorder. When you call this as an autoimmune disorder, this is more common in women rather than men, right? And what is the age group at which you see this systemic sclerosis is? That is around 3rd to 5th decade of life, the systemic sclerosis is more common, or symptoms. The clinical features of systemic sclerosis is more common around 3rd to 5th decade of life. And if you take female to male ratio, it is around 3:1. Now, if you observe the etiopathogenesis of the development of the scleroderma, the likely trigger for the excessive fibrosis, it is the combination of the immunological response, right? It is the combination of the immunological response and as well as the vascular changes, right? It is the combination of the immunological response and the vascular changes. Now, apart from this, there are many drugs which are responsible for the development of scleroderma, and that includes the following. That is vinyl chloride, bleomycin, pentajocin, aromatic hydrocarbons, carbidopa, tryptophan, and as well as the rapeseed oil. And this scleroderma, it is of two forms. What are these two forms of scleroderma is? One is diffuse scleroderma, right? And the other important form is the limited scleroderma. Now, in case of the diffuse scleroderma, there is a widespread skin involvement, right? There is widespread skin involvement and there is rapid progression of the disease. So in the sense, the fibrous tissue immediately gets accumulated within the skin and as well as within the internal organs as well. Whereas you take limited scleroderma, the limited scleroderma, as the term itself tells you, that there is limited skin involvement, where the skin involvement, it is just confined to the fingers. The skin involvement, it is just confined to the forearms, and the skin involvement, it is just confined to the face. This is what is called as the limited scleroderma. And here the progression of the disease is a slow progression, and the visceral organ involvement is also late, right? The visceral organ involvement is also late. Now, some of these patients with the limited scleroderma, they develop what is called as a crest syndrome. The word C is the calcinosis, R is Raynaud's phenomena, which is most common in case of scleroderma. E stands for esophageal dysmotility because of the fibrous tissue accumulation. Sclerodactyly, where there is accumulation of the fibrous tissue within the skin of the fingers. And dilated capillaries, that is called as telangiectasia. And this is what is your Raynaud's phenomena. So Raynaud's phenomena is like when the extremities of the hand, like when exposed to the cold. So initially the fingers, they turn pale in color and then blue. There will be like cyanosis. And later, because of reflex vasodilatation, they turn into red, right? So this is what is the changes that happen in the Raynaud's phenomena. And this Raynaud's phenomena, it is of two forms, primary and as well as secondary Raynaud's phenomena. Primary Raynaud's phenomena, it is also called Raynaud's disease, where we don't know what exactly is the etiology. It is like idiopathic. We don't know what is the underlying cause. Whereas at secondary Raynaud's phenomena, you have a definitive cause. For example, systemic sclerosis. That is one of the cause for Raynaud's phenomena, and there are multiple causes for the Raynaud's phenomena. And these are all the diseases which are associated with the Raynaud's phenomena, like scleroderma, systemic lupus erythematosus, rheumatoid arthritis, Sjogren's syndrome, dermatomyositis, polymyositis, and vasculitis. These are all the diseases associated with the Raynaud's phenomena. Now, let me also show you the skin changes that you will have in patients with the scleroderma. So, initially, the development of the ulcers or the fibrosis of the skin will start from the tip of the digits. So, it is the skin over the tip of the digits is where the abnormality will begin. And even if you observe the nails in these patients, you will have what is called as a multiple pits over the nails. Okay, these are called as the pitting scars or the pits. And over the skin which is involved, there can also be formation of the ulcer over the skin, right, which is affected over the tip of the digit. And if you see the mouth of these individual, right, they have what is called as microstomia. Right, they have what is called microstomia, or this we call it as pinched facies. Right, this we call it as a pinched facies or the microstomia. Right, so where there will be reduced mouth or reduced lip opening during eating. Why? Because of the excessive fibrous tissue accumulation. And in advanced stages, there will be fibrosis of the salivary gland also. Thereby, there will be reduced salivary production in these patients with the systemic sclerosis. And thereby, there will be difficulty in swallowing the food. There will be dysphagia in these patients. And not only that, if you take the GIT manifestations, there is dysphagia. What could be the reason? One is because of decrease in salivary secretion. The other thing is there will be also oropharyngeal sclerosis, and thereby there will be difficulty in swallowing the food. So dysphagia is one of the feature. And once the swallowed, the esophagus also becomes fibrosed, and there will be constriction of the lower esophageal sphincter. So the food from the esophagus, right, will try to regurgitate back. So GERD is also very common. So the oral manifestations will be damage to the enamel, right? There can also be development of the dental caries, and there will be retrosternal pain. So these are the upper GIT manifestations. Then you take musculoskeletal manifestations will be in the form of the symmetrical arthritis. Because the fibrous tissue gets accumulated within the synovium, there will be hypertrophy and hyperplasia of the synovial soft tissue resulting in arthritis, but it is a symmetrical arthritis. And renal involvement can also be there. That will be in the form of the renal artery stenosis, where there will be fibrous tissue accumulation or systemic sclerosis within the renal artery. So thereby renal perfusion decreases, RAS gets activated, that will result in the hypertension. Okay, that will be the kidney manifestations. Then you take the lung manifestations will be in the form of the fibrosis. So that will result in the development of the restrictive lung disease. So once there is a restrictive lung disease, like what will happen to your FEV1 by FVC? FEV1 by FVC will remain normal or increased, but diffusion capacity of the lung for carbon monoxide will be reduced in case of restrictive lung diseases. And what is the most common cause of death in patients with scleroderma is pulmonary artery hypertension, and that is because of the development of the ILD. Whereas if you take another connective tissue disorders like SLE, the most common cause is infection. Whereas in rheumatoid arthritis, the most common cause of death is accelerated atherosclerosis causing coronary artery disease. And in these individuals, cardiac involvement is also there, and that cardiac involvement will be in the form of the restrictive cardiomyopathy, or there can also be development of pericarditis and pericardial effusion. And myocardial fibrosis is what is responsible for restrictive cardiomyopathy. And because of this restrictive cardiomyopathy, the relaxation of the heart will get impaired, and that will result in what is called as diastolic dysfunction. Right? That will result in diastolic dysfunction. And if you take the workup in these patients, the ESR is being elevated because it's an autoimmune disease where there is an inflammatory component, and anti-nuclear antibody is positive, but it is not specific. It is a non-specific marker because it is also positive in SLE. Then what is the investigation of choice? The investigation of choice in case of limited scleroderma, the antibody is anti-centromere antibody, right? Whereas in patients with diffuse scleroderma, it is anti-topoisomerase antibody, right? Anti-topoisomerase antibody, right? And apart from this, the anti-SCL70 will also be positive. So these are the antibodies that you come across in patients with the systemic sclerosis, and they are considered to be the investigation of choice, right? Then how do you treat these patients? The drug of choice in those individuals who are symptomatic will be the steroids. Okay, so the drug of choice will be the prednisolone. And if you take the individual disorders, like for example, there is esophageal disease causing reflux, GERD. So you need to give the proton pump inhibitors, that is mainly to reduce or subside the GERD component. Now, even the other important molecule is the octreotide. Now, what is the purpose of giving this particular octreotide is, it is a somatostatin analog. It helps in some patients with bacterial overgrowth and as well as the pseudo obstruction, right? Bacterial overgrowth and pseudo obstruction. And in some patients where there is delayed gastric emptying, right? In patients where there is delayed gastric emptying, you need to give oral prokinetic drugs. And these oral prokinetic drugs, that includes metoclopramide, right? The oral prokinetic drugs, that is metoclopramide, that helps in like gastric emptying. So those individuals with delayed gastric emptying, the metoclopramide and one more drug, that is cisapride, can also be given. And in those individuals where there is malabsorption due to bacterial overgrowth, in them rifaximin should be supplemented. This rifaximin 550 milligrams thrice daily should be given. And this rifaximin, it is an antibiotic which will suppress the bacterial overgrowth. And in those individuals who are having scleroderma renal crisis due to renal artery stenosis, in them you need to give ACE inhibitors, and this particular ACE inhibitors, that includes the captopril, right? Because why are you giving ACE inhibitor? Because the hypertension is due to excessive activation of RAS. So for that reason, you need to give captopril. And those individuals who are having interstitial lung disease, they will be requiring the treatment with mycophenolate mofetil, and this will improve the dyspnea, in the sense like that will reduce the shortness of breath of the individual, and it will improve the quality of life of the individual. And in those individuals who are refractory to mycophenolate mofetil, in them you need to give nintedanib, right? Who do not respond to mycophenolate mofetil, then nintedanib is another important drug for the ILD. And these patients also develop pulmonary hypertension, and the drugs that we need to give is the bosentan, which is an endothelin receptor antagonist, right? Now, what is the advantage of giving the bosentan? Bosentan, it will improve the exercise capacity of the individual, and it will improve the cardiopulmonary hemodynamics, right? And the other group of drugs are phosphodiesterase 5 inhibitors. Examples include like sildenafil, tadalafil, and as well as the vardenafil. Then we have guanylate cyclase stimulant. This is a new molecule. And what is the example of it? This is 𝗑𝐳𝐺𝐸. So 𝗑𝐳𝐺𝐸 is a guanylate cyclase stimulant. Then we have endothelin 1 receptor antagonist. Examples of endothelin 1 receptor antagonist will be bosentan and as well as macitentan. These are the examples of endothelin 1 receptor antagonists, right? Then if the individual is refractory to the above molecules, then we have prostacyclin pathway agonist, that is epoprostenol, treprostinil, and as well as the iloprost. And how is the prognosis in these individuals? See, in patients with the scleroderma, that is diffuse scleroderma, in diffuse scleroderma, the prognosis is bad, right? Prognosis is worst. In limited scleroderma, the survival rate is up to 9 years in 40% of patients. But in diffuse scleroderma, the prognosis is bad. So this is about the scleroderma. So let me quickly recap. Scleroderma is a clinical condition which is characterized by excessive accumulation of the fibrous tissue within the skin and as well as the multiple organs. And it is an autoimmune disease which is more common in females rather than males, right? As such, what exactly is the etiology is not known. It could be because of the combination of abnormal immune response and vascular change. And there are certain drugs which will be causing scleroderma, that includes vinyl chloride, bleomycin, pentagocin, aromatic hydrocarbons, carbidopa, tryptophan and rapeseed oil. And we have two forms, diffuse and limited scleroderma. Diffuse, where there is widespread skin involvement and rapid progression and early visible organ involvement. Limited scleroderma, right, where there will be limited skin involvement, confined to fingers, forearms and face, slow progression, right, and some of the individual develop what is called CREST syndrome. And the important clinical manifestation is development of Raynaud's phenomena. And Raynaud's is not just observed only in systemic sclerosis, also observed in SLE, rheumatoid arthritis, Sjogren's syndrome, dermatomyositis, polymyositis and as well as vasculitis. And the skin involvement mainly will be from the tip of the fingers, where there will be like digital ulcers, where will be pitting of the nails. And if you see, observe the face of these individuals, they'll have microstomia or pinched faces. Then they'll have dysphagia because of decreased salivary secretions, and oropharyngeal dysphagia is also very common, and esophageal dysmotility is the one which will be causing GRD and retrosternal pain, and there will be dental caries and as well as damage to the enamel. And musculoskeletal changes will be in the form of symmetrical arthritis, renal manifestations will be in the form of renal artery stenosis, pulmonary manifestations in the form of interstitial lung disease and pulmonary arterial hypertension. Cardiac involvement will be in the form of pericarditis, and then restrictive cardiomyopathy. ESR is elevated, ANA will be positive. Investigation of choice is anti-centromere, anti-topoisomerase antibodies, and the drug of choice is steroids, and symptomatic management to be given. So this completes the discussion of systemic sclerosis. So in this session, I'll be discussing a very important topic, that is achondroplasia. So achondroplasia, it is a genetic disorder, right, where the individual will be short, and this is one of the common cause for dwarfism, right? And why does it occur? This occurs due to mutation of a particular gene called fibroblast growth factor 3 gene, right? So it is due to mutation of fibroblast growth factor R3 gene, and this particular gene is what is responsible for regulating the bone growth, right? So this is the gene that is helpful in regulating the bone growth. And what happens whenever the mutation of this gene is, whenever there is mutation of this gene, there is abnormal cartilage formation, and this abnormal cartilage formation, it particularly affects the long bones, right? It particularly affects the long bones, and that will result in the development of the shorter limbs, large head and the normal sized torso, okay? And how will be the head of these individuals will be, there will be a very prominent head, right? There will be a very prominent head, okay? And the nose, if you observed, there will be flat, right? There will be a flat bridge of the nose, right? So there will be flattened bridge of the nose. And if you observe the fingers of these individuals also, they have a short fingers, right? They have the short fingers. And if you observe the IQ of these individuals, that is intelligence and life expectancy, it is normal, okay? So IQ is absolutely normal, right? And these patients, they can have associated health issues like spinal stenosis, right? They can have associated health issues like spinal stenosis, and whenever there is development of spinal stenosis, they will be requiring the medical intervention. And it is a genetic disease. What is the type of inheritance of this disease is, it is an autosomal dominant type of inheritance, which means just one copy of mutated genes is enough to cause the disease, right? And how will you diagnose this is like prenatal and postnatal diagnosis. Prenatal diagnosis, it is like by ultrasound, genetic testing. So in ultrasound, achondroplasia can sometimes be detected through the prenatal ultrasound. Especially, you will be able to detect achondroplasia in the later stages of pregnancy by observing the characteristic features of the shortened limbs, right? By observing the characteristic features of the shortened limbs, you will be able to make out the diagnosis of achondroplasia in the later stages of pregnancy. And not only shorter limbs, there will be also large head in the ultrasound and as well as abnormal skull shape. Now genetic testing, this is like performed using amniocentesis, right, performed using amniocentesis or chorionic villus sampling, right, or chorionic villus sampling. Now by doing this amniocentesis or chorionic villus sampling, you will be able to detect this fibroblast growth factor R3 mutation. So that is what is your genetic testing. And if you take the postnatal diagnosis, right, you need to do the physical examination. So upon the physical examination, you will be able to make out disproportionate short stature, right, there will be disproportionate short stature. That is one thing. Second important, there will be short limbs, right, there will be short limbs. And if you take the facial features, there will be abnormal facial features. So this will be upon physical examination. And if you take the X-ray, X-ray can reveal the specific patterns of the bone growth, right, where there will be shortened long bones, right, long bones, they are shortened. That is what you will observe within the X-ray of the limbs. And even you will be able to make out the abnormal characteristic shape of the skull and spine, right, abnormal characteristic shape of skull and spine. And if you take the genetic testing is what is your definitive diagnosis. And what is that genetic testing will recognize? This will identify fibroblast growth factor R3 gene mutation. Okay, that is what is your genetic testing. Then how do you treat these patients? You need to give the growth hormone therapy. In some cases, growth hormone therapy may be used to increase the height of the individual. It is used to increase the height of the individual, though its effectiveness is variable and it is not a standard treatment. Next is the surgical treatment. It is orthopedic surgeries may be required to correct the bone abnormalities, and these orthopedic surgeries will correct the spinal stenosis, right, and these orthopedic surgeries will also correct bowing of the legs, and these orthopedic surgeries will also relieve the pressure on the spinal cord. Okay, so this is what is the surgical treatment. And next important is managing the complications. So you need to regularly monitor for the complications, such as there can be development of ear infections, there can be breathing problems, there can be obesity. So these conditions require specific treatments like hearing aids for the ENT problems, right, weight management because of obesity, and sleep apnea treatment should be given because of development of the OSA. So this is about the achondroplasia. So achondroplasia, this is a disorder which is a genetic disorder where there is dwarfism, and it is due to mutation of fibroblast growth factor R3 gene, and that is, this gene is responsible for regulating the bone growth. So whenever there is mutation, there will be abnormal cartilage formation, particularly affecting the lung bones, resulting in shorter limbs, large head, and as well as normal sized torso. And even if you take the head, there will be prominent forehead, and the bridge of the nose will be flattened and shortened fingers. The intelligence and life expectancy are usually normal, right, and there can be health issues like spinal stenosis which will be requiring medical intervention. And achondroplasia is inherited as autosomal dominant type of the inheritance, right, and diagnosis, prenatal diagnosis is by ultrasound and genetic testing, postnatal diagnosis is by physical examination, X-ray, and genetic testing. So in the genetic testing, that is considered to be the definitive diagnosis, and this can be confirmed through a blood test that identifies the FGFR3 gene mutation. And in the treatment, growth hormone therapy should be given. Surgical treatment is required to correct the bone abnormalities such as spinal stenosis and the bowing of the legs. And you also need to monitor and manage the complications. So this completes the discussion of this very important topic, that is achondroplasia. Thank you very much.